young at heart too. So I just want to acknowledge the young people for allowing me to cramp their space as an adult. Me and Dominic, we know that we have cramped your space, but I thank you for allowing us to be here. And we are going to have an engaging session where we are going to have different speakers. So we just want to say to our viewers online and on Zoom to say, please feel free to drop a message. If you've got certain questions, we'll find a time where we can answer those questions, or we can give you a platform to ask certain questions. And to the team in-house to also say, can we have an engaging session? At some point we will get scientific, so feel free to ask and to bring your ideas forth. Before I go any further, I will just give Dominic to say a few things before we get into our speakers for the session for the day. He will just give us a background, where are we from and what are we looking forward into. And we just want to appreciate HCAAP for partnering us in a very tiny but beautiful kingdom. Thank you, Dominic. Welcome.
Thanks, and it's a great pleasure to be here. I'm going to keep opening remarks very short, because I will come back and speak to you a little bit later, and I'll talk to you about HCAAP and what we're trying to do. But we have, you can see, I'll try and get the screen to work properly, but Moses Supercharger on the phone. And Supercharger is a huge advocate. He does a lot of work in Uganda, but around the world, around HIV generally, and has been involved in cure efforts for some time. And what we want is to see more superchargers in this world, more people from the community who are in global conversations around cure, who are influencing and bringing a community perspective to what's happening around cure research, cure development. Cure is not going to happen tomorrow, but today we're going to give you an idea of the journey. As I've described to Precious, today is the beginning of the beginning, okay? And even when we get to the end of the day, we'll still be in the beginning of the beginning, but I hope we'll have some questions about how we might want to move this forward in Eswatini. So, Supercharger, can you hear us? Are you speaking?
Yes, I can hear you, Dominic. How are you, dear?
You are booming in this room. The volume is very good. Okay, so with that, we're just trying to sort out the projection, because we can't get, we're not getting you on screen, but we can hear you very loudly and clearly, and I want to respect time. So maybe whilst we're working on the getting Zoom to show your face on screen, we could see you. You're just a bit squashed. This way? This way? Maybe you can go ahead, Supercharger, and get started. I've already introduced you, and we'll get the visuals here working in a moment.
Yes, good morning, dear folks. I'm called Moses Supercharger from Uganda. I'm a person who has openly and positively lived with HIV since 1994. So I've spent 3 decades with HIV. But as you can see, I'm looking very healthy, and I happen to be the most handsome-looking guy in Africa, purely because I take my medications correctly, and I adhere to the medications, the instructions of the doctor. Today, I've come to discuss with you a very important subject, that is a cure of HIV. And basically, my presentation will talk about 3 areas: what, why, and how. What is an HIV cure? So as a community advocate, before you even start advocating for a cure, you must understand what you are advocating for. You must know what you are fighting for. You must know what you want your country to get involved into. So you must clearly define and understand the product you are advocating. So this is a product which is still in research. We don't have a cure yet. So you also have to know very well as an advocate. So you must define a cure. As a community advocate, you must use whatever language you use in a community-friendly way. So even if you're talking about definition of an HIV cure, it must be in a community-friendly way. So as an advocate, you will be invited in your community to talk about this cure. How will you define it? What is it? It is still under research, but you need to find it, to define it. So in simple community language, a cure simply means an intervention that someone with HIV can take, and it completely removes the virus away from his body. Or it can be an intervention that someone with HIV can take, and it doesn't completely remove the virus, but that person can stop the daily medications. That person would not infect the partners, and that person will not be falling sick, will be a healthy person. So in other words, the definition of a HIV cure is in two ways when you are defining it. It must be, the first definition was eradication, complete removal of the virus from your body, and you don't have any virus. That is called eradication. Or another one, it can be an intervention that you can take, and the virus is still there in the body. When they test, they can see it, but you don't need medications every day. And that cure which you took can control the viral load. It controls the viral load, but you don't infect others, and you live a healthy life. So you must start by defining a cure in a community. Defining the cure as an advocate, as a person representing the community of your area, you must know the reasons why you need an HIV cure, why we should go for an HIV cure. For instance, I'll tell you, I've lived with HIV for 30 years plus, but I'm looking healthy. Somebody will ask, if Supercharger can take medications and he looks handsome, he looks healthy, why do we waste time in finding an HIV cure? Let him just take his medications until he becomes 100 years. So you must have reasons to say, even though Supercharger is looking nice, he takes his medications and looks nice, he takes his medications and is healthy, we need it. You must have reasons. I want to briefly give you some of the reasons you can use to advocate for an HIV cure. One, adherence. Supercharger looks nice. He's taken medication for 30 years. He's looking nice, he's healthy. But you don't know the challenge he goes through to take these medications every day. Right now, I'm miles away from my home. If I forgot my medication, I'll be on tension here. If I forgot my medication, I'm likely to develop what I call resistance. So the challenge of taking these medications every day, this medication, there is no medication which is sweet. All medications are sour. Think about the children who were born with HIV and have to take these medications for so many years. And they go through this every day. If there was a cure, these people would have been saved. So that should be your number one reason as you should champion for, as you champion for an HIV cure. Two, another reason why you should champion for an HIV, tell them, okay, we have ARVs which can make people look healthy and good, and they cannot infect others. But these medications are not bought by our country. They are bought by other countries, the Western world. And these Western worlds, they are just giving us a donation. Anytime they can say, no more funding. If that happens, people will die, millions of people will die in Africa, because as Africa, as a continent, we can't buy these medications for our people. Our economies are too poor to sustain our populations. We can't. I'll give you an example. My country, Uganda, United States of America gives us $400 million every year to buy ARVs. Just imagine if one day America says no more funding to Uganda. My country, we have always had what they call a deficit budget, which means we spend more than our revenue annually. So we need support from other countries. Another reasons why you should stand for one HIV cure. People have taken medications, you know very well, and they have run out of treatment options. Somebody took first line, it failed. After some time, he was put on second line, it also failed. After second line, was put on third line, it also failed. And then we don't have fourth line. We only have first, second, and third line. He's on third line and it is failing. So what do? Do we just let those people die? In Uganda, we have 1,560 of those people on the third line. And if their medications fail, they will just die. So we need to champion for an HIV cure as a savior for those people. Stigma, we are being stigmatized, denied opportunities everywhere we go because we have HIV. Why do they stigmatize us? They stigmatize us because they think we are infectious, because they think we shall die next year, we don't have no future. They stigmatize you because they think you can't work as a negative person. Comes the person who has been stigmatizing you will not do it because he will know that you are just like a person who is negative. So as an advocate, after knowing the reasons as you should fight for an HIV cure, you must know how this cure is likely to work. You must go through the strategy, the different strategies researchers are using to find an HIV cure. Quickly, we know very well that an HIV virus, for it to survive and cause trouble, it must do all that trouble inside a white blood cell called a CD4 cell. So without a CD4 cell, it will not cause trouble. So the target of this virus has already been a CD4 cell. It will go in your CD4 cell, enter your CD4 cell, manipulate your DNA because you know very well your DNA is inside your CD4 cell. It will use your DNA to make more HIV viruses in your body. Now, researchers are concentrating on that. Okay, if the HIV virus to cause trouble, it has to enter the CD4 cell. Can we find a way of preventing this virus from entering the CD4 cell? Even if it has already entered somebody's body, but then can we create an intervention which can prevent it from entering the CD4 cell to cause trouble? Oh, can we just make the CD4 cells of a person resistant to this enemy coming in the body? So they are using different options. Another option they are using, immune-based, your immune system. You know, you get HIV today and you start falling sick after like 2 years. Why are you not falling sick when you already have HIV? You get today, but you don't fall sick the following day. It will take you like a year or two without falling sick. You are not falling sick because your immune system is fighting this enemy. This enemy will start making you sick when the immune system has been overpowered. So the immune system fights the enemy for some time. So researchers are saying, if that is the case, one way of curing HIV can be engineering the person's immune system. Just periodically engineer his immune system so that this immune system can be able to fight the enemy without ARVs. So that's another form of trying to cure HIV. So there are different strategies researchers are using to cure HIV. These ones, you must know them. And I must tell you, my brother and sister, it took me like 4 years to understand them. So don't say it will take you one day to understand. Never. You need to go through it every day, on and off, different strategies. Different strategies. Immune-based therapy. They are trying to engineer the immune system so that it can fight the virus. Oh, then you get that. Then you can try another one, the gene therapy. They are engineering my genes so that they can be resistant to HIV. You need to go with them slowly by slowly, so you cannot understand everything in one day. Lastly, as an advocate, what is your role? Your role, number one, is understanding the strategy, understanding the agenda, the cure agenda. you must know everything to do with an HIV cure, because it is you who will pass this important information. Role number one is making sure that you understand these things in your own understanding. Don't take the scientific language of doctors and researchers. Break it down in your language and understand it so that you can pass it to your community properly. So role number one is understanding this cure agenda. Role number two, after understanding, you must translate this agenda to your community. How do you translate it? Translate it in a language people understand, and you must be able to answer all questions that they are asking you. And if there are some questions that are challenging, don't get offended, because everybody knows you are not a researcher, you are not a doctor. Go and ask your doctor. Doctors and researchers are there to help you. Ask them these questions and go back to the community. Role number three, you must advocate for cure studies to come in your country. 95% of the cure research that is going on around the world is in the Western world. It is not in Africa. It is not in your country. Why? Why is this agenda not in Africa when the majority of people with the problem are in Africa? 38 million people are living with HIV globally, and 21 are in Africa. And you are doing cure research, and you are doing it in a country where there are not people with HIV. So you should advocate for these trials to come to your country. And when these trials start in your country, you don't stop there. You must advocate for only trials that are safe for your people. Advocate for safety of participants in all studies. If you see a study and you are not so sure about the safety of your people, consult the investigator. Consult us so that we can contact them and put them to task to explain. So don't advocate for any trial that is not safe for your community. And the second last one is try to involve all key population groups in the ongoing research. The trans people, let them participate too, because they're also human beings. The MSM, let them participate. They're also human beings. Let everyone, let all the children also participate in research. And there must be different designed trials specifically for children. Children should not participate in adult trials for cure. What are the tricks? The last one, I just want to give you like 2 or 3 tricks that can help you understand this cure agenda. Trick number one, you must know the life cycle of HIV. If you want to understand the cure agenda and the cure strategies clearly, first and foremost, you must understand the life cycle of HIV. HIV has like 7 stages immediately after infection. So you must to cure HIV. So you must go through the life cycle of HIV. And what I do normally when I'm presenting, when I'm talking to community, the first thing I do is to go through the life cycle of HIV in a community language, and they understand it. It's really very important. Trick number two, attend all community cure sessions, even scientific sessions. If there is a cure meeting, ask to participate. Appoint them, go and participate and ask your questions, because their role is to answer your question. I've attended different cure sessions and people just keep quiet. No. As they present, write down the questions, and after presentation, ask them the presentation, because their job is to answer you. The researcher's job is to answer your concern and your questions. Please ask them. I'll stop there, but I must say, next time I would really love to come and join you physically, because to joke with you, to interact to network with you, which I can't do on. Next time, I would really love to do it live. May God bless you.
Thank you, Supercharger. Thank you, Supercharger. We got most of that right at the end. There was a little bit of sound issues, but I think most people got what you had to say. So, Supercharger is still online. If he was here in practice, you would be singing and dancing. That's how he does his in-person workshops. It's harder to do via Zoom, but he still has a little bit of time. So he's put some challenges to you in terms of how you move forward, some tricks. He's also talked to you about, the why, the how, why this is relevant to this group. Do you have any questions for Supercharger? If so, please get the mic, put your hand up, and he'll answer what he can. It's a bit quiet in the room, Supercharger. I'm not sure they're awake yet. Okay, one sec. Precious?
Yes. Thank you so much. I call you my comrade because it's been 30 years I've noted. My name is Precious. It's the issues around the cure. It's something that I'm very keen of, and I'm so much passionate about it. But maybe from your own experience, how have you managed to make sure that you advocate for more cure trials to be done in your country, and maybe if you know a little more a little more about Swaziland, what would you say, what can we do as advocates to ensure that we also can pave way for more HIV cure trials to come to our country too? From your own, what has been your learning? What is your advice? How have you been going around things?
Wow, that is a great question. Thank you so much, sister. First and foremost, you must attend all those cure sessions, the policymaker meetings, and please, one of your questions should always be the involvement of Africa and your country in particular. And the way I've done it, because I've been blessed, and I have attended hundreds of meetings internationally, meetings in America, but the first thing I do, if I see that they are doing something, if I see that they are doing something in America, we need to know why are they not doing it in Africa. And by doing that, I've had cure trials come to my country. So the best thing you can do is to ask why it is not happening. And another thing you can do is also to work with your policymakers, the Ministry of Health in your country, the scientific committees in your country, and ask them, because some of them don't even know that actually these trials are happening. Yeah, they are medical doctors, they are researchers in your country, but you'll ask him about, I study HPTN 052, what happened? And he'll say, what is that? But he's a medical doctor, but you don't blame him, but because he might be a medical doctor doing something very different from research. So you need to keep in touch with your managers in your country and put them to task. Ask them why this is not happening. By doing that, they will bring it. I'll give you an example. One of my policies, I was an AVAC fellow in 2017. And one of the things that I advocated for was introduction of third line medications in my country. My country had only first and second line. And yet, personally, I had realized that actually there are some folks who were on second line and they were not doing very well. And they were taking their medications correctly. You know the problem health workers have? When they see you not, they will say, you're not taking a medication. You're not. No, it's not that. It's not true that a person, every person who is not looking good is not taking medication. There are those folks who are taking their medications correctly and the medication just failed. So my country didn't have alternative. So I advocated for its introduction And I went to the Ministry of Health. I told them, we need third-line medication. They said, there are no third-line medication globally. I told them, you're lying. Because I know there is a combination of laltagravir and this medication and Novil, which you can combine and give as an alternative, somebody failing second line. So when they checked, they realized it's happening in the Western world and they brought it. If I had not asked, if I had not told them that it's happening in the Western world, they wouldn't have brought it. So you need to stand up and ask them and put them to challenge. I hope I've answered your question. Thank you.
Thanks, Supercharger. Do we have any other questions in the room? Please, come on.
I would really love to have at least 5 questions. Because if I don't get 5, I'll know I've not done a good job.
Greetings, colleagues. My name is Mandisa Dlomo. What I took from your brief presentation was that us not having a queue plays a major role in the country's economy since it's expensive. So my question is, how do we then work towards getting funds to do the research in our country? Because at this moment, one of our concerns in Eswatini is that we don't have enough medication. For the longest of times, we've been getting medication for like 6 months, but now it has been cut down to a month since we are lacking medication. So how are we going to advocate for fundings? Whom do we talk to? How do we go about in terms of that? Thank you.
Supercharger, 1 second. The sound's been cut. 1 second.
I didn't get the question.
Okay, so the question was around funding and that there have been cuts in funding in Eswatini recently. And so how do you how do you advocate to ensure that there's sufficient funds to undertake cure research in country? Oh, 1 second, we're having a sound issue. We're just 1 second, Supercharger. It's coming there. Okay, you should be fixed now. Go ahead.
Am I clear?
Yeah, you're clear. You're clear.
Yeah. Right now, the global investment into an HIV cure is not really very beautiful. It's just $330 million. And majorly, 90% of that funding comes from NIH, which is National Institute of Health. And underfund other funders like Bill and Melinda Gates Foundation and pharmaceutical world. And so as an advocate, it's you to know where this money is and stand up for it. Stand up for it. I mean, the trick that basically I use is these meetings. Whenever you get chance to attend these international meetings, stand up and ask this question. Amazing things have come out of these meetings from the community. If you stand and bring this question up, somebody with money will be in the corner there. It will say, hey, you mean there is no cure research going on in Swatini? And then you will bring the money. So you can start by doing that. 2, we can also work with your governments. These governments of ours also have some money. Urge them to start small with the little they have, to start with it. So I'll answer question in 2 ways. The best way to get this cure funding is to network with NIH. Attend meetings, ask questions, let everybody know that this is not happening in your country and you are ready for it, you want it. They will bring it definitely. In Uganda, we didn't have cure research, but I'm glad to tell you that we have like now five, 5 entities cure research in Uganda because of standing and demanding NIH to bring these studies in our country.
I might just add to Supercharger's answer there, because he mentioned the 330 million for cure research globally, which is small when you think of the billions that are spent on the HIV response. But that's also because we're at an early stage in cure research, right? So most of that is going to research laboratories. And one of the reasons why HCAAP is supporting workshops like this with the network here is because we believe that because it's still at early stage, this is the right time to be talking to communities for at least two reasons. One is to do the things that Supercharger's talking about, is not to think about who the funders are now, but who the funders are in the future. And the only way change happens is when there's advocacy for it. So if communities start saying, well, we see what the science is saying, we think this is important for our future, we think there should be funding to support this, including the work with communities around literacy, then that will happen. But that will be a process of time. But sometimes the money is not there, it has to be advocated for. The second reason, and this is what Supercharger also mentioned throughout his conversation, and I just use it as a reminder, is that there is cure research going on right now, and largely it is dominated by people in the Western world. And if we want people from the continent most affected by HIV to be part of cure processes in a much, much more active way, we need more advocacy to make that happen. And in so doing, that will hopefully also open up funding opportunities. So there's like little cycles, but there is very little money right now on the table for cure research for communities in particular. But what we're starting a discussion, I said today's the beginning of the beginning, right? Today's the beginning of, well, how do we plan so that in a year's time, 2 years' time, 3 years' time, more money is available for this work? Okay? All right, any other questions? Okay, please.
Thank you so much, Supercharger, for such a wonderful presentation. I just want to ask some few questions, like how is Supercharger working with other organizations and other stakeholders in advocating for the HIV cure in his community? Secondly, I wanted to ask, how do you engage your government, or what strategies do you use to approach the government to help you advocating for the HIV cure in your country? Thank you.
Yeah, thank you so much. That's another great question. How do I do it in Uganda? I must say, first and foremost, I've worked with different organizations internationally. I'll give you an example, like AVAC. AVAC is Global Advocacy for HIV Prevention. It's based in New York, but it gives annual scholarship projects to you people, advocates. I hope you know about it. And if you have not known about it, please, you need to find it. Google, interact with them, and find ways of working with you. These AVAC people will support you to do a project which you can use to advocate for something in your country. So I was the very first person to advocate for involvement of community into HIV cure research in the country. I just wrote this proposal, and they were also amazed because ever since they started, they had never seen an application to do with cure advocacy. Never. All the applications they receive are to do with PrEP, pre-exposure prophylaxis, post-exposure prophylaxis. We want to introduce a ring in our country. We want to do this. We want to circumcision in my country. For all the 10 years, they had never seen a cure-related application. So mine was the first, and that's why it scored highest. And I received a grant to do an advocacy project for 1 year. My advocacy was to advocate for community involvement, empowering some few community advocates to start with so that they can use that information to other communities, and also to push the government to get involved. So you need to find these organizations. You need to network with these following organizations if you are a cure advocate. You need to network with Caring Cross. You need to network with HCAAP. You need to network with ACTG, which is AIDS Clinical Trials Group, because they are doing the biggest cure research in the world. You need to network, find a way of networking with the GGTI, which is Global Gene Therapy Initiative in Africa. So by working with these networks, they'll help you. They'll help you first and foremost to break down the science. If the opportunities are there, they'll come to you first. If HCAAP gets funding and they want to fund community advocates, they will start with you because they know you are doing the job. So you need to know these organizations and work with them and find a way of seeking funding so that you can push your advocacy in your country. Thank you so much.
Okay, we've got one more question here.
Thank you so much.
Wow,
greetings
I'm
everyone.
glad.
Race Banyoni, okay, the member of the LGBTQI community. So I've heard that you said that gays and transgender people should be involved in the trial. So I want to ask if you have involved them in your country, and how is it? Because we know as much as we want to be involved, we have to deal with the government that we are in. Some of the government that we are in doesn't allow or recognize the gay community, the MSM. So I wanted to know how is it that you have worked with them? Because we, at the end of the day, if we want this to work in the country, we need to involve government. How to deal with the government if we are part of the LGBTI community?
Dom, you're gonna break the question down for me.
Okay, so Supercharger, the question was around, because you mentioned that cure activities at a community level should engage LGBTQ groups, so MSM, transgender groups you mentioned. And so the gentleman was asking, so in Eswatini, these groups are not recognized. So how have you, what is the experience from Uganda, where I think also the government position is similar, how have you undertaken to engage those groups in cure process at a community level? What are the learnings that that you might be able to share?
Oh, that's a good one. Thank you so much. Okay, what's happening in Eswatini is what is also happening in my country, Uganda. These groups are not recognized, but by you not recognizing a snake does not mean that the snake is not there. Are we together? By you not recognizing a chocolate in a supermarket when you enter a supermarket, it does not mean the supermarket does not have chocolates. So my country is barbaric, I will say, does not allow freedom of some folks, but they are there. But they are there. So as an advocate, when I'm inviting advocates to come and participate in my meetings, I don't exclude them because I know they are there. So our governments are just pretending, and we must fight this pretense. They are there, and they are the people with the, how should I put it, with high risk. They are the people who get HIV more than other groups. You need to start with them. So to answer your question, when you are inviting these people, please don't isolate key population groups. Don't isolate LGBT people. Don't isolate people living with HIV. Don't isolate sex workers. Don't isolate, because put everyone on board. Ignore what the government is doing, because the people you are inviting are not going to come with placards saying, I'm a transgender. No, they're not going to do that. So if they're not going to do that, why are you not inviting them? So stick to your idea, stick to your line that these people are important, they exist, and we need them to get involved in all advocacy work that we are doing. Thank you so much, ladies and gentlemen.
Thank you, Supercharger. And I think the message there is cure is for all, right? And so regardless of how we might identify different groups, all need to be part of the discussion. We've got another question, Supercharger.
Hi everyone, my name is Simpwe Matsebula. Supercharger, my question is on the research meetings that you talked about. I would like to know, how does one get to know where to find those meetings? Because I have never really attended one in my community, or let alone hearing of it. So you also mentioned something about international research meetings, of which we don't know where to find them. If you can maybe tell us where we can find them, and if everyone is able to attend, or there is a certain criteria that is needed for a person to attend.
Thanks. Did you get the question, Supercharger?
Yes. Where do you get the networks, the QR networks, right? That was the question.
The question is...
Now, these meetings...
Oh, go ahead.
Yeah, these meetings I talked about happen annually. For instance, I'll give you an example. There is a scientific conference happening in Australia this very year. And applications, scholarship applications for you advocates are closing 4 days from today. Have you applied? Have you tried to apply? Because scholarships are open. I'll give you an example. IAS is organizing a scientific conference in Australia this year, July, but they opened scholarships for you 24 days ago, and they are closing and 4 days from now. So you try and apply. The simple question they will ask is, why do you want to apply? You need to give them the motivation why you want to apply. And you know all these things. Try. And if you fail, try another time. There are different meetings happening, really different meetings, QR meetings happening. And I will ask actually HCAAP. HCAAP, one of the things that they need to do in the future is to put us together as a group. All advocates they have empowered, maybe create something like a WhatsApp group or a network group whereby they can communicate all these informations. Right now, you don't know that this is happening, that this scholarship is in 4 days from now. Should be getting this information from networks like HCAAP. Get in touch with AVAC. With AVAC is posted on their website. On their website, please. And so many others. So the best way is to try yourself and know the things. But there's no way you can know these things if there is no someone to communicate them to you. And we need to ask HCAAP, AVAC, all those networks to pass all those updates to you. Thank you.
Thanks, Supercharger, and thank you for the task. I can actually say that two things that we've just recently started doing or proposing to do. So first is some meetings are physical, right? But if there is a silver lining to COVID, is that a lot of things now happen online. So for example, there is a meeting next month at a scientific conference called CROI in Seattle. And there is a pre-conference cure workshop, which is open to anybody. So I've already shared the link with everyone we work with, and I think Precious. I said she's link for CROI. And I would suggest that's open to anyone. So if people are interested in going to that workshop, it's on a Saturday, and I'm afraid that the timings are on West Coast time for the US, so it's like it starts at like 5 o'clock in the afternoon here. So, but if you can get together as a group in an office or a place where you have a Zoom connection, then that is a great way to start, right? The only cost is your time. The second thing that we are going to start doing, because as Supercharger mentioned, we now have started working with a lot of different local organizations in Africa, and we want to be working with yourselves, right? We don't want to be the people at the conferences speaking. We want, in the future, for those spaces to be filled by our partners, because you're the ones in the communities who are representing the communities most affected. And so that transition is going to take time, but it will happen. But as a step towards that is we're going to organize a call, probably the first one in February, where we bring all the partners together that we've worked with, and that will be open, relatively open, if others want to join, you know, who haven't been part of the organizing committees, but just participants, and they're just really keen. And the idea there is to share what's going on in each country. But as I mentioned to you at the very beginning, before Supercharger started, this is the beginning of the beginning. What we hope to come out of today is not that you'll be experts, cure advocates that can start doing cure literacy tomorrow. What we're hoping is that it sparks an idea like, okay, so what do we want to do? What do we want our plan for Eswatini to be? Okay? And you won't be the only group of people thinking about that. We've got people in Uganda who is a little bit further ahead, Zambia and South Africa, who are also having these conversations. So let's link everybody up together. And at those calls, we can also ask people who are organizing webinars and other things to join. There is another group that Supercharger mentioned called Caring Cross, and they are they're a strange entity. There's a private, like, commercial side, but there's also a charity element. But on every Friday, they've got webinars, and those webinars are, some of them are very scientific, very high science. I go in and I don't understand a thing. But some have been
corner.
Yeah, but some are communities. I've presented. Supercharger probably has too, and everything is recorded. So even if you've missed ones, you can go see them afterwards. So there are resources out there which will make sure you get to learn about. But absolutely, if you don't know what you don't know, right? And so what we want to try and do is not just spark an interest in this space, but also start to connect you with one another.
Now, Dominic,
go ahead.
Quick one. Okay, CROI is happening 10 days from now. You might not have chance to attend, but one of the things that you can do is actually look for somebody who has attended that conference in your country. When he returns, can you ask him to organize a simple committee meeting to tell you what happened at that conference? A PI of your research entity has attended, and when he returns, can you write to her and say, dear madam, doctor, you attended CROI, but as community, want to know what happened. Did they talk about cure? What new things about cure research happened? Did they talk about vaccine? So you can also use that trick. Secondly, the last one which I want to share with you, many of you get chance to be invited to these international meetings, but people don't attend these meetings. After getting a visa, boarding a plane, you go to America, you start visiting parks. The meeting is going on and you are not attending. And those who attend will sit in a meeting and go on WhatsApp. So you need to use every opportunity you get. If you are invited, go and attend. It's only 3 days, and use those 3 days maximally. Ask questions and network. By networking, I mean try as much as possible to interact with the pharmaceutical world, interact with the different global researchers. Ask them to come to your country. Ask them, why are they not coming to your country? Thank you so much, Dom.
Thank you, Supercharger. Thank you. So with that, we've got our next speaker I know is online, but I hope you will give Supercharger a big round of applause for being with us today. Thank you. There are a few people who, all of whom you'll be speaking with today on this call, who have been absolutely instrumental to all of these workshops, who always, whenever I say, would you mind making some time available for this community in whichever country, always put their hand up, and Supercharger is one of these. So Supercharger from us, thank you. Thank you for your support today and for the lively discussion and answering all the questions. I think one or two of the takeaways I will just, excuse me, reiterate is just to be active. We know that to be confident, you need to have a little bit of knowledge, and we hope that today will be the start of a little bit of knowledge. Supercharger, in every one of his comments, kept on saying, you have to go ask the question. You have to be a bit pushy. You have to make your presence felt. So I think that is a really important thing, because sometimes we sit in a room and we're a little bit scared or a little bit like shy to say anything. But what we want Cure to be on the research agenda. We want, to be on African research agendas, and we want Africans and people from across the continent to be part of activities that are going on in other parts of the world. And that's not just going to happen magically. So we need more people like Supercharger, advocating. He talks about how he wants to live to 100, and so he's got a lot of advocacy ahead of him to help him get there, and why he wants a cure. But I hope that he won't be alone in this mission over those next 50 years, that he'll be joined by many of you in that advocacy, and that we will have a cure well before then. So thank you, Supercharger, and really appreciate the time again today. And I will then now move on to our next speaker, Philista. Philista, are you online?
Yes, Dom, I am.
Wonderful. Thank you for joining us today. So, Philista, just so you know, we've got excellent sound, 2 ways, and people could see you on a computer screen if you want to put your camera on. If not, don't worry. But we don't have a big screen working right now, so they will be hanging on your every word. So,
Right.
Philista is a wonderful advocate from Kenya who I've got to know over the last 2 or 3 months. Passionate, just like Supercharger in many ways, and working in her communities around Cure, amongst other things. So Philista's going to talk to you a little bit about her experience and her tips, if you will, for you around undertaking community-level activity around Cure. So Philista, can I hand over to you?
Yep. Thank you so much, Dom. Am I clear enough? Thank you so much. So I can go ahead and start. I'm really humbled and excited to engage the network of young positives from Eswatini. And I hope it's going to be a very fruitful engagement with you, and you're going to learn from the experiences that I'm going to share with you today. You've already been told my name, but I would like to also share with you that I am a beneficiary of the IS, that is the International AIDS Society, and EVAC Fellowship for HIV Cure. So I was so green, just the way you are very green about HIV cure. I was involved in a lot of HIV prevention work and treatment, but I did not know that there was a possibility of having a HIV cure. But then it came to my knowledge that there is this new concept or idea that scientists have come up with about HIV cure. So able to make an application to the HIV Research Cure Academy, that is in 2019. Engagement, I was able to learn more about HIV cure, what it is, the strategies that scientists thought could be able to help us either control or cure HIV. So I got really passionate about this because growing up in my community in Kenya, I come from Kenya, and I come from the lakeside region of Kenya, that is Kisumu. This is an area whereby HIV really killed a lot of people. We have infants who are perinatally infected with HIV, and we also have adolescents who are sexually infected with HIV, because the prevalence of HIV in this area, Kisumu, is double the national prevalence in Kenya. So that is the sorry situation that we had. So growing up in my village, I was doing then an anthropological study in my rural community, and I was deeply embedded into this community. So I lived seeing people dying each and every day from HIV, and the sorry state was young people dying in the 90s without any medication. So I was helpless. But when KEMRI came in and began to provide ARVs through the support of the Centers for Disease Control in my community, then I began to strongly advocate for young people to go to the facilities to be tested, because my community did not believe that it was HIV. My community believed it was something, a cultural disease known as Chira, whereby someone has bewitched you to get it, or you did something wrong, that is why you have the disease. So it was not really easy to make my community, my young people, and even the older adults to go to the clinic. But we ensured that they were tested and put on ARVs, and through the results that they got from it, people were encouraged, and we could see that there were better health outcomes out of it. What really motivates me also in the HIV prevention landscape and now the cure landscape is that I would like to tell you today that HIV prevention and treatment is the backbone of HIV cure. We cannot have HIV cure minus prevention, minus test and treatment. Because if you are tested early, that is when you will know your status, and then you will be put on treatment. So these really still remain the main focus that we need to encourage our communities to go for testing, so that once they are tested, they are put on treatment. And then we have the cure component coming in, because we still do not know whether the cure component will be for those people who've been tested early or for those people who've lived with HIV for quite a long time. So these are strategies that are still being tested. So I was able, during my advocacy fellowship after the academy, I was able to apply for some little grants to conduct some advocacy work in Kisumu. And I engaged the adolescents in my work. I was able to engage sex workers. I was able to engage the MSM, the vulnerable groups in my community, religious leaders. I was able to also engage health workers in this work to tell them more about HIV cure, which is a new idea that scientists think that is going to grant us a breakthrough, because we hope by 2030, we should really end HIV in our communities. And we can only obtain this if we amplify our voices on HIV cure and tell our communities, why do we need HIV cure? One of the things that I learned while working with the adolescent is that the issue is a big issue. Most adolescents prefer to go on treatment holidays, of which there is no scientific evidence whether it works or not. And now that we are engaging you today, I think you will share with us more information on how best you think we can go through this. And also another issue is the issue of stigma, non-disclosure, because most of the adolescents, especially those who are infected through their mother, perinatally, they are living, taking medication that they do not know what the purpose of this medication, because they're just being told you are sick and you have to take medication all your life. So this is a dilemma. And this usually raises questions such as like, why me in the community? Why do I have to take medication for the rest of my life? So this is a question that HIV cure can come in and address it so well. Because if we have an HIV cure that can control the virus, maybe for about 1 year or 2 years, then the burden for these adolescent is going, or infant is going to be reduced. The issue of pill fatigue is also going to be addressed in the same capacity. So these are things that if the youths can tell us better. The issue of counseling, how do we approach the counseling on issues of stigma? And that is in terms of internal stigma and external stigma among infants and also adolescents and young people in general. So these are areas, and also we need to understand what are some of the barriers that make infants, for example, and also adolescents not to take up HIV prevention. And also now that we are coming with HIV cure, is it going to be easy for adolescents to take it up, or are we going to have some challenges? Supercharger, who came just before me, talked to you about the language of HIV cure, the science of HIV cure. If you look at the language and the science of HIV cure, it's a little bit complicated and it might scare you away. And you might feel that this is not meant for you. But I would assure you that with proper engagement between you, the young people and the scientists, we will be able to engage everyone and ensure that everyone understands the cure language so that we may actively participate in HIV cure research. One area, as an advocate, a young advocate, a youth advocate in your country, one thing that you really need to ensure that you have first is ensure that you have the knowledge. You have the knowledge about HIV prevention, HIV treatment, HIV care, and the care continuum also. And also do research on HIV cure, because this is a continuous knowledge that is building from one knowledge to another. So once you equip yourself with this, able to engage your fellow adolescents, you'll be able to engage your caregivers, you'll be able to engage the healthcare workers with the right and the correct information about HIV cure. So it is your responsibility to study also. You have to read, look for this knowledge, look for these resources. And today I'm asking you, like, engage HCAAP and tell them that you really need this information, because when you are talking, it is like most of us do not have information about HIV cure. It's new knowledge, but you can only have that new knowledge if you have the hunger to seek this knowledge so that you may be able to impart this knowledge to other people and ensure that the knowledge you are giving does not cause misinformation, but you are providing the accurate information. Misinformation is also another challenge that we know in biomedical research, and we don't want to have misinformation around HIV cure. So let's engage the experts. let's ask the experts who are going to engage you on HIV cure. What do you mean by this terminology? Like if I talk about HIV cure, what does it mean? So that when I go back to the young people community, I'm able to tell them by HIV cure, I mean, this is a strategy or a way of controlling HIV or completely removing it from the body, so that you provide the right information in a simplified manner and able to make someone really digest the information and make an informed decision whether they want to participate in this HIV cure research. We have terminologies like ATIs. What is an ATI? Make sure that you ask the researchers who will be here today, what is an ATI? An ATI, it's analytical treatment interruption, whereby the treatment of ART will be interrupted, but it will only be interrupted under monitored conditions. It will not be applicable. You should not go outside there and begin telling the other young people that, oh, so we can interrupt heart without any problem. It will only happen in a very controlled situation. So ask these questions. What are BNABs? Broadly neutralizing antibodies. I know Supercharger during the tricks has told you these are the soldiers that help our bodies fight. But ask, what does the word broadly mean? Yes, they are the soldiers. Who does what? Huh? Who broadly fight the diseases in the body? Or who broadly fight the different strains of HIV that we have in the body? So that is why they are called broadly neutralizing antibody. And if you can help the scientists today, as you go through your slides, help them understand what is the best way to speak to the adolescents so that they may be able to understand the HIV cure knowledge in order to make a decisive decision. And then you'll be able to amplify your voices outside there and engage the young people. So another way also as a community of do and what your greatest contribution can be in the work of HIV cure is you are quite innovative. There are quite innovative ways on how you can also help the researchers, the social scientists, to impact the HIV cure knowledge to our communities in a very simpler and interactive, likable manner, such as use of animated videos, whereby you can develop videos that really identify with the young people, make them to understand the science in a simpler way, and enable them to make a decision on whether they want to participate in these researches. We would like to understand, if at all we are going to bring an HIV cure that is going to target the pediatric and young people, what are we supposed to do? Because you know best what the youths really required. What do you require in the HIV cure? How best can you be engaged as a young community? Through which medias? What kind of information, education, and communication material do we require to target the young population that is disproportionately affected with HIV? In my community, we have really high numbers of HIV infection among the adolescents. And in every year, the numbers keep on increasing. And with the COVID pandemic that we had, the number has really increased and we are a worried people. So we need to really understand how best can we engage you to improve the uptake of HIV cure intervention or drug therapies that are going to be there targeting adolescents. How are we going to handle issues of disclosure among the adolescents? You have the skills, you have the knowledge. What advice do you have for the HIV cure experts so that we may be able to really address these issues so that they do not become a barrier to the implementation of HIV cure? And some of the ways that you can be, because after this training today on HIV cure, I believe you are going to be an advocate of HIV cure. And as I had said, that an advocate of HIV cure, you have to hunger for that knowledge. So you'll be looking for more and more resources to make you have the right information. So you can amplify your voice as an advocate in the first place on HIV cure. You can be a champion of HIV cure, whereby you can use the existing groups that you have at your community or in your nation to amplify the voice of HIV cure so that people can be aware that there is a possibility of curing HIV. You can amplify your voice in terms of need. Engage HCAAP, engage EVAC, engage International AIDS Society to provide more for you among adolescents and young people so that you have the knowledge. Use those advocates like Tokmo, who is there. Use Tokmo, use other, maybe Precious, who is near you also. Use them to link you to these networks so that you may be able to obtain this knowledge and be a leader in HIV cure. You can also begin forming youth advisory groups that will be able to review the HIV cure protocols and provide your input on how best you think they can be implemented in your country or in sub-Saharan Africa in general. Use this opportunity to also discuss on ways that you think HIV cure service delivery can be improved or incorporated in our normal public health system. And also have discussion on how the aspects of stigma, because stigma has really hugely impacted on HIV treatment and care. How is it going to impact on HIV cure? What are the expectations of the young people on HIV cure? And what are your perceptions? Be a leader on how are we going to address issues of myths and misconceptions that come up with any new interventions that we've had. We've had a lot of misinformation. We've had a lot of myths and misconceptions regarding the COVID-19 vaccines. So how are we going to really address issues of myths and misconception regarding HIV cure as adolescents? And what kind of myths and misconception do we anticipate from the young population? Because you are privy to this information, you know what people think, and how best can we address this so that it does not affect the uptake of HIV cure? How are we going to ensure that our infrastructures are well developed? We need to begin to engage our national government. We need to engage our Ministry of Health. We need to engage HCAAP, EVAC, and IS and tell them, as much as we are talking about HIV cure, but we need to have a platform from where we are going to begin from. We need to empower the advocates with adequate information, the right information. the youth can be a leader also in translating a translation of the cure language, the cure terminologies that are not easy. So because the meaning of cure perhaps in Eswatini is different from the meaning of cure in Kisumu, Kenya. Because in my language, the Luo, cure means two different things. transfer this knowledge to other people. Being a cause or a root cause for misinformation in the community. So always be ready to learn and always be ready to accept when you are not sure when you do not have that knowledge. Be ready to acknowledge that and tell them, I do not know about that, but I'm going to find out more about it. You can use also activities. Adolescents are engaged in various activities like games. You have tournaments, different tournaments. You can use those forums to engage other youths about it, about HIV cure, and get their the feedback from them. And what do they think about something that is possible? Is it something that they think it's going to work? Is it something that they think it's, how can we implement it and make sure that it is successful? And what are some of the things that we also require? I know that maybe the infrastructure for adolescents might be different. What do we require as adolescents in terms of infrastructure? What can enable us really understand HIV cure and be confident about it? So we need to look at these things and ensure that we are champions and the right champions. And when we become passionate about HIV cure, because I know from this meeting, after this workshop, you'll get out and really feel confident that you know more about HIV cure. I'd like to caution you, go slowly, digest the HIV cure knowledge slowly, and make sure that you also reflect and ensure that what you are talking about is really the right information. I'll leave it at that point and also open up for questions. Thank you.
Thank you, Philista. Thank you for that. There was a lot there, so hopefully you've all caught a little bit of this. As always, we've got 5-10 minutes for questions. So if people have questions, let me know, put your hands up. But one thing you mentioned early, Philista, which I think might be useful to this group. This is a group that for the first time is starting to think about, talk about cure. You mentioned being an advocacy fellow as part of that advocacy fellows program. How did you find out about that? How did you apply? Just in case this is something that people in this room might want to think about in future years. Could you just give a little bit of insight practically how you got into that program, just so that they can hear that for themselves?
Okay. Thank you so much for that question. So how did I get to know about this fellowship? First, I'm working in a research setup. So at some point, I got an opportunity to travel to South Africa for the HIV Prevention Networks Trials meeting. And during that engagement, we had some EVAC fellows who had come to attend. So during was, I don't know, the president of EVAC then, Kevin, And we had a talk with him, and I really told him that I've heard about EVAC really doing a lot of work with people in different countries, and I would like to know what the process is. So he was able to share with me the details and told me, unfortunately, by that time, the fellowship had closed. So I still went ahead and wrote and expressed my interest. And I got a letter of regret. They told me the same thing he had told me, that the fellowship had closed. So thereafter, the following year, I was really out looking for any announcement or advertisement that would come out. So when it came out, I made an application. So when I made this application, I was able, fortunately, because I had now the HIV cure knowledge, I was able to write a strong proposal, because I was participating in the AMP study, which was also trying a broadly neutralizing antibody here in Kisumu. So I had more knowledge about it, and I wrote my proposal, and luckily enough, I was selected and given that grant.
Thank you. So AVAC has come up several times today. You can find them online on the web. The program is done jointly with the International AIDS Society. Please, if this is something that is of interest after today, and these are programs that you think you might want to do in the future, you need to, there's a little, we have to be a bit proactive, right? Not everything you have to be on the mailing list or whatever, but you can sign up to newsletters and things like that, so that the message comes to you. Okay, do we have any other questions in the room? Oh, got two questions here. Okay, so please.
Hi, Auntie. My name is Sipasi Shemabaso. I'm also a young person living with HIV. So my question is, most young people suffer from depression and have mental health issues caused by stigma and discrimination. So my question is, how can we as advocates make sure to reach out to the community in helping the youth to overcome and to teach them more about the struggles of HIV, and to offer them counseling and to monitor them? Also, to give them knowledge on how to live and break barriers caused by HIV. Thank you.
Did you get that, Felicity?
Oh. So your question was on depression, discrimination, mental health issues, how you can provide education to the adolescents.
Is that right?
Okay, so I got it right. So first of all, I would like to acknowledge that issues on mental health have not been well addressed in the HIV cure programs. And I think this is bringing it up now. And I think this is something like under the HIV cure, this is something that we really need to amplify our voices and say that we as adolescents, we have a challenge on mental issues problem. And we need to find a way on how these can be incorporated in the HIV cure implementation, so that we are able to address this issue to ensure that the uptake of HIV cure intervention is up. And also we have counselors who've been instrumental, and also psychosocial support peers we've had. So it doesn't have, when it comes to mental issues, so it varies. Different individuals have different issues. So you cannot really generalize. You can give a general talk on mental issues, but then it requires that you narrow down to now the specifics of this person. Because if it is depression, what is this person depressed from? You see? So you need to find out that and link up this person with either a specialist to help this person, because you cannot really address that issue as per se. And this calls up, I will say, Dom, that we need to, during, as we work on HIV cure implementation strategy, we need to include mental health component and ensure that we have psychologists embedded into the HIV cure studies to address these issues.
Thank you, Phyllis.
Thank you.
And I would say, I would add to the discussion about complexity. So the session I normally do, very short, is normally at the beginning. We'll do it a little bit later. But let me just quickly ask before we go to the next question. Has anybody ever been cured of HIV? What are the answers? Yes, no? Has there been anybody cured of HIV? No. So the answer is actually yes. We know of at least 5 cases. But these were people who went through a bone marrow transplant, and the donor had a natural immunity to HIV. Okay? So this is a very complicated process. They were being treated for cancer. Okay? So they had HIV, but they also had cancer, bone cancer. And when they were being treated, that's how they, and Tumbi, in the next session, will talk a little bit about this, right? And the reason why I mention this is that, as I've mentioned, there are a few people living who have been cured of HIV. One, the first, a guy called Timothy Ray Brown. Have you heard that name before? Okay. He was cured about 30 to 40 years ago, but he actually sadly passed away for other reasons last year. But he and others, though, do talk about, even if you have a cure and you are cured, there are mental health issues associated with it. Because you're no longer positive, but the people, that community of people you're around. So where do you fit? You know? You were positive, now you're negative. So the mental health issues associated with cure are both now in terms of what does that mean as we move forward, and are we talking about things in the future when people are having challenges today? But it also has to be part of our preparations for if there is an eventual cure, because part of people's identity for a long time will no longer be there, and that will have impacts, right? So if we're successful in developing a cure. So mental health, a big issue. I think you had a question?
Good morning, everyone. My name is Lucky Chele from Eswatini. Thank you so much. Thank you so much for such a wonderful presentation. I did enjoy when you said you can never cure HIV while we are leaving behind early HIV testing and adherence. I was so much glad to hear that. But my questions, my worry is about the non-disclosure and stigma among young people, in terms of, here in Eswatini we are having a challenge in terms of stigma and non-disclosure, whereby we are facing it even in our families. So my question is, how did Kenya reach out to win and tackle these challenges in terms of the young people? Because he doesn't know anything, he doesn't understand anything. Please help me with that.
So thank you so much for that great question. So issues of non-disclosure and stigma are real in HIV. And from my experience, I was able to work in a pediatric HIV study. And I would like to tell you that I faced this issue face to face, and we had to handle them. For example, I would like to give an example of whereby the woman tested on her own when she was pregnant and discovered that she was HIV positive. and did not disclose to the husband. So she's been on HAT for the 9 months, and then she delivers, and the husband does not know that she is on HAT. So that is where the challenge begins of non-disclosure, even before now the child comes in. So here is a situation whereby your husband does not know that you are HIV infected and you are living together. You've brought in even a baby that because we were counseling mothers to exclusively breastfeed, and then they will stop. So the challenge came in whereby the husband would want the mother to breastfeed, and then she's already been told to stop breastfeeding. So the husband will question, what is it that has brought this up? And then at another stage is when now the child, because most of the kids that we saw through are now about 10 years. So these kids also began asking, and why those who were infected, most of them were not infected, but for the few who were infected in this study, they also began asking, and why am I on medication always? What is wrong with me? And yet the other children are not on medication. So this made us to develop a model whereby now we had to bring the partners on board and educate the partners on the importance of couple testing, whereby we could test the couples together. And most of them, when you explain to them you have to test them with the partner, they understood and agreed to testing, although a few, for those couples who agreed to be tested together, it was easy because then there were no complications and they could work together until the child was of age, and then they were able to disclose for the child. For those couples who could not be tested together and they were blaming each other on, you know what you are suffering from, and that is where you've told the people at the clinic to test me, I'm not infected, so they will blame each other. We would just continue counseling them in the hope and reaching out to the men in the hope that they would at one point accept to be tested together so that we will break that issue of non-disclosure. Stigma is still a big issue in my country. I wouldn't tell you that we've made a huge stride. We are still struggling with it. And we know very well that stigma has got two faces. We have internal stigma, whereby it is you who is actually stigmatizing yourself, always walking around and thinking that people are thinking you have HIV or whatever. So it's your mind speaking to you. And at times it becomes very tricky to address such issues. And also external stigma is a reality at different levels. So the only thing is we still continue to provide that information in the hope that everyone will be able to understand. A good example is we are having an adolescent study that is going on for adolescents infected with HIV. And we've been able even to engage the schools because there was a lot of stigma that was coming from the schools where they were studying. So we've been able to engage the teachers and explaining to them that even if you are not infected, but each and every person is either infected or affected with HIV in one way or another. So for us to really have good treatment outcomes, we need to work in partnership to ensure that our adolescents are taking their medication without any stigmatization, without feeling that when they remove the bottle, then you're going to say, in my language, that these are the people who are swallowing the pill, you know, they ridicule them like that. So we've tried to address, but we have a long way to go. Yeah, thank you.
So I know it's tea break time, so are there any last questions or a last question Okay, one more question, Felicita. Here you go.
Thank you so much. My name is Tulani Dlamini. From our previous speaker, Supercharger, he talked about forms of HIV cure. So from you, I want to know if from HIV cure component, does the component require someone who is newly diagnosed or someone who is been on treatment for a very long time, for a specific time? Because there's one doctor that I'm following on TikTok. He has said that they have injectables in South Africa, which you take them for 2 months, but you need to be virally suppressed for that. So I want to know, do we have some interventions for the HIV cure component to say if you're newly diagnosed, you can still go onto this HIV cure component? Thank you.
Felicita, do you feel able to respond to that? Or?
Yeah. It's super challenging, but I can. So the challenge that we have with HIV cure is the HIV reservoir. That is the hiding virus that hides in the various hidden part of our body, like the armpits, down the brain. So that is where the HIV hides, and the size of the HIV reservoir. So that is why scientists are thinking that perhaps if you are tested early and put on treatment early, then the size of the HIV cure might be smaller, and it might be easier to target it and eradicate it completely. So these are thoughts that are there. But when it will come to that particular time that we have the HIV cure, then we will get to know whether it's maybe some strategies, as I had said, some strategies might be applicable for those people who are newly diagnosed. Maybe it will work best for them. And maybe some strategies might be better for those people who've lived with HIV for quite a long time. Thank you.
Thank you, Felicita. And I would save that question for Tumbi when he's on after the break, because he will tell you, because this is one of the things that has come up amongst the researchers, those people who are doing the work. Very clearly, the goal is a cure for everybody infected, right? It's not supposed to be for a segment. But there may be some groups that it's easier to see cure in initially, but the goal is cure for everybody. So with that, I know that there might still be some discussion, but we've got time for discussion, Q&A. Tumbi's going to join. I can answer questions. But I hope you will join me, give a round of applause for Felicita. Thank you for making the time. Felicita has also been a great supporter, and I think one of the things, really, the reason why I asked Supercharger and Felicita to give their perspectives are, whilst there are some commonalities in what they've said, there's lots of repeated messages, right? Their experiences are different, and these are two countries that are neighboring, Uganda and Kenya, right? So you will see similarities, but you will also see differences. So with that, please go have tea, coffee. Please come back in the next kind of 15 minutes or so that we can get the next presentation going. Thanks. We've got about 30 young people in the room. Maybe you could see off on the camera them in the room, and we've had conversations with Supercharger and Philister this morning, looking at community perspectives around cure. We've just had a coffee break, and they're really keen to get into the science, aren't you all? Yeah. So we're really, really privileged today to have one of the leading scientists in Africa working on cure with us, joining us remotely from Durban. Dr. Tombi Ndungu is brilliant scientist, but also really committed to community support and engaging communities in the work. And he's going to, I'm sure, talk to you about some of the work he's doing in communities in Durban through the FRESH trial. But I just want to say that I hope you will be captivated by the science and all the things that we've been talking about today. And please store your questions. If you have questions as he's going through, write them down, be ready for when we get to the end so that we can answer and clarify anything. So with that, please let me hand you over to Dr. Ndungu. Thank you. Tumbi, over to you.
Thank you very much, Dom, and good morning to everyone. Dom, will I be able to see the slides? Or
you won't, because I've got them on a separate laptop. So if you open them locally, okay, then I will follow you.
I will just use my own slides here, and I'll tell you when I'm going to the next slide. Hopefully,
I'll move to the first slide away from this from the title slide.
Okay, so my name is Tombi Ndungu, and I'm going to talk about strategies to achieve HIV cure. This is going to be primarily a scientific talk. So I do apologize if some of the terms sound very complex and difficult, but please do feel free to interrupt me if there is anything you don't understand. I'll be very happy to answer any questions. And probably it's best if I just go through because I'm not there in the room, it might be difficult for you to interrupt me when I'm talking. So maybe what I'll do is I just go through the talk, and then we can ask questions at the end. Maybe it's going to work better that way. So let's go to the next slide, Dom. And I had animated that slide, so I'm just gonna ask you to, not just show everything that is on the slide. But what I wanted to show with this slide is the advances that have been made in terms of our ability to treat HIV over the past 2 or 3 decades. You can see how antiretroviral therapy looked like in 1996. People had to take about 30 tablets in one day in order to treat HIV infection. Today, in 2023, most people take just one pill of antiretroviral therapy. So there has been tremendous change and development in terms of the way ART is delivered. And of course, we also know that there is a long-acting antiretroviral that has now been approved that can be given once every 2 months, so that people don't have to take antiretroviral therapy tablets every single day. So I just wanted to make it very clear that there has been a lot of progress made in terms of the way we treat HIV infection. But having said that, there are still some challenges, and I'm going to discuss some of these challenges with antiretroviral therapy. And then I'm gonna discuss some of the strategies for HIV cure that give us some hope that there might be a cure in the future. And then I will very briefly discuss a cohort that we have established here in South Africa called FRESH, in which we are doing HIV cure research. Please go to the next slide. The next slide is taken from the Daily Nation. Is actually story that was run in the Daily Nation, which is one of the leading newspapers in Kenya. And it talks about how some people are struggling with antiretroviral therapy, because antiretroviral therapy, although it is very effective, it has to be taken for life. And some people have really struggled with taking antiretroviral therapy. And I thought this story that was in the Daily Nation was very insightful, because it talks particularly about teenagers, some of whom have lived with HIV since they were born, and some of them don't even know why they're taking a medication every single day, because their parents did not disclose that they were born with HIV. So I think the point that this story illustrates is that some people, it is very, very difficult to have to take antiretroviral therapy for the rest of your life. And unfortunately, at the moment, although, again, as I said, antiretroviral therapy is very effective against HIV, it has to be taken for life. And so we need to find a solution to see whether we can develop something where people don't have to take antiretroviral therapy every single day. So what is the problem? Why do people have to take antiretroviral therapy every single day? Now, when somebody gets HIV infected, and now I'm on the third slide, Dom, when you take antiretroviral therapy, it suppresses viremia to undetectable levels, so that you cannot detect viral load in somebody who is taking antiretroviral therapy. The problem is that as soon as antiretroviral therapy is interrupted, the virus comes back, and usually that happens within 2 weeks. So for most people, as soon as you interrupt antiretroviral treatment, within 2 weeks, there will be what we call a viral rebound. Why does this happen? This happens because although antiretroviral therapy is very good at suppressing the viral load to undetectable, it doesn't eliminate HIV from the body. There are some cells in the body that are sleeping cells. We call them latently infected cells. So these cells have HIV, but they are quiescent, they are sleeping, and as soon as antiretroviral therapy is interrupted, these cells will start producing new HIV virus. And so one has to take antiretroviral therapy for life to prevent this rebound of viremia from these latently infected cells. So this is why antiretroviral therapy cannot be interrupted. So the next slide actually shows two forms of HIV infected cells. One is what we call productively infected cells. So somebody who is not taking antiretroviral therapy has what we call productively infected cells. So these cells will be DNA positive, they are HIV RNA positive, and they are also HIV protein positive. So they produce HIV virions. And these cells usually will die because of HIV infection. And that's why you find that somebody who is HIV infected, the cells, particularly the cells that are infected with HIV, they die, and the CD4 cells are very low. The numbers of CD4 T cells in somebody who is HIV, who is living with HIV, who is not taking antiretroviral therapy, the numbers of CD4 cells go down because the cells keep dying because of HIV infection. But as I mentioned, there are other cells that are what we call latently infected. So these cells are not actively producing HIV, but they have HIV DNA in them. And so these cells can survive for very, very long period in the body. They can survive for decades, for very many years within the body. These cells are HIV DNA positive, but they don't produce HIV RNA and they don't produce HIV virions. So these are the cells that we call latently infected cells. Now, next slide. The next slide shows that latently infected cells, particularly in somebody who is taking antiretroviral therapy, are very, very rare. So they are very difficult to identify. They are about cells. So only about 1 in a million cells will have latent HIV infection. And there is no way, there is no simple marker that we can use to identify these cells. So they look almost exactly like the rest of the cells, and there is no way to identify them. And these cells are mostly CD4 T cells. So this is why it is so difficult to cure HIV, because of these cells that are very difficult to identify. But even though they are very difficult to identify, and even though they are very rare, 1 in about a million, they are there in the body and they are circulating. And as soon as ART is interrupted, these cells will start producing new virus. Next slide. In the next slide, I show a slide called HIV controllers. And what I wanted to show with this slide is that there are some people who are HIV infected who have never taken antiretroviral therapy, but despite the fact that they do not take antiretroviral therapy, they are able to suppress viremia, HIV viremia, to undetectable levels. These individuals are called HIV controllers. So these are individuals who are living with HIV, but are not taking antiretroviral therapy, and their viral load is undetectable. These individuals are very, very rare. It's a very small number of individuals. Most people, when they get HIV infected, they will progress to full-blown AIDS if they are not taking antiretroviral therapy. But there is a small group of people, less than 1% of the population, who are able to naturally control HIV infection. And these people also have normal CD4 counts. Now, in approximately 60% of these cases, HIV control is associated with a particular cell type, immune cell type in the body, known as CD8 T cell. So it is the CD8 T cells that are involved in the control of HIV in these individuals. But there may be also other mechanisms involved. So this tells us that in some circumstances, it is possible to control HIV without antiretroviral therapy, even though we don't fully understand the mechanisms, and even though there are very few people who are able to control HIV without antiretroviral therapy. Next slide is named post-treatment controllers. And post-treatment controllers are people who are also able to control HIV without antiretroviral therapy. So there are some people who are able to control HIV without antiretroviral therapy, but most of these individuals started treatment during the acute phase of infection, or very, very early after they got infected. So some people start treatment soon after they get infected, and then because of various reasons, those people interrupt treatment. And for some of those individuals, again, it's a small number of people, but they exist, the virus does not come back. So these people are called post-treatment controllers. So these people started treatment in acute HIV infection, and then they interrupted treatment, and then the virus does not rebound. So this group of individuals shows us that HIV remission is possible, but it's infrequent. And this group of people is very important because studying the mechanisms, trying to understand why is it that some people are able to control the virus. So antiretroviral therapy interruption is very important and might lead us to new ways of curing HIV. So HIV cure, the next slide shows a few cases of HIV cure, where HIV cure has been achieved. One example is a gentleman by the name of Timothy Brown. This person was living with HIV in Germany. He developed cancer. He underwent what we call a bone marrow transplant. But the bone marrow transplant donor, the person who gave him the cells to replace his own cells, because when you undergo a bone marrow transplant, what they do is they remove all your cells and they replace them with new cells. So what happened to Timothy Brown is that he received a donation of blood from somebody who does not have the receptors that allow HIV to enter cells. And that receptor is called CCR5. So that person received a bone marrow transplant and the virus did not come back. Another example is a gentleman called Adam Castell, also known as the London patient. This person also underwent a bone marrow transplant, and this happened in 2019. And as far as we know, the virus has not come back. He has not had a viral rebound. So he seems to have been cured of HIV. And more recently, there's a woman in New York who also underwent a transplant, what we call a cord blood transplant. And this person also seems to have been cured of HIV. So although HIV cure is possible, it's also very rare. And also the procedures that have been used so far to cure people of HIV are not very safe. They are very dangerous procedures because a bone marrow transplant is both dangerous because you can die from it. A lot of people, when they undergo transplants, they don't survive, but also it's very, very expensive. So these are not methods that can be used to cure most of the people who are living with HIV. So although they have worked, these are not methods that can be rolled out to the general community because they are not safe and also because they are very, very expensive. And then I also, of course, told you that there are people who are called post-treatment controllers. So there are many people who are treated very early during HIV infection. They interrupted treatment. And there are also a few other patients that have been reported that have been cured of HIV. So when we talk about HIV cure, what are we actually talking about? What is an HIV cure? There are two ways to think about HIV cure. One is complete eradication, where no virus is detectable. So this would be a complete cure of HIV so that the virus is no longer detectable. But the other possibility is what we call remission, where the virus is still present at low levels, but the person is not taking antiretroviral therapy and cannot transmit the virus to their sexual partner because the viral load is very, very low. But this person will remain antibody positive by the normal HIV tests that we normally do in the laboratory. So that's what we call remission. Now, there are various ways to achieve an HIV cure. So one, as I said, is to eradicate the virus completely. So remove all these latently infected cells from the body. And that, if you do that, you can achieve what we call an HIV cure. The other possibility is to reduce the number of infected cells. And there are various ways that you can do this, usually by boosting the immune system. So you can progressively reduce the number of infected cells. And this is what we call remission. So both of these strategies are being attempted. And it is thought that scientists think that maybe a remission will be much more likely compared to eradication because it's easier to control the virus than it is to completely eradicate the virus from the body. So what are the ways of eradicating the virus? How can you completely eradicate the virus? There are various ways that are being attempted, and I have listed them here in this next slide. This slide is called Targeting the Virus and the Immune System through Combination Immunotherapy. So one possibility is to provide very early antiretroviral therapy. There's another way where you can what it's called latency reversal, where you take these latently infected cells and you stimulate them so that they start producing virus, because usually they are quiescent, they are not producing any virus, but you can stimulate them so that they start producing the virus. You can also give drugs that can cause these cells to die, although the problem here is that we don't have good tests to identify these latently infected cells. There are other methods such as giving immunotoxins latency silencing, where you can make these cells that are latently infected with HIV become completely silenced, so that they will never be able to produce virus. And then there are also gene editing technologies that are now being pursued to try and get rid of the virus within these cells. So those methods that I've just mentioned target the virus. But the other way to do this is to boost the immune system, so that the immune system itself is able to control the virus. So, and again, there are many approaches here, such as using broadly neutralizing antibodies, vaccines, immunomodulatory agents, gene editing, and other technologies known as, for example, CAR T cells. These are all methods where you boost the immune system so that you can eradicate the virus or control the virus that is circulating in the body. Now, most of these approaches for HIV cure are actually being used in combination. So the next slide, called HIV latency reversal, shock and kill, shows how this is done. So you have these latently infected cells, and because they are latently infected, they are not able to produce HIV by themselves. But you can stimulate them with what we call a latency reversal agent, so that they start producing HIV variants. So if you're able to do that, that induces these cells to start producing HIV variants, and then the cells will die. The other possibility is to then boost the immune system, so that the immune system by itself is able to kill these cells that start producing the virus, new virus that comes up. So that's one way so it's a combination approach, because one, you're using a latency reversal agent, and then you are enhancing the immune function in the body, so that the immune system by itself is able to kill virus-infected cells. So this diagram here shows some of the combination approaches that are being used to cure HIV. One, as I mentioned, is very, very early antiretroviral therapy. So the earlier you start antiretroviral therapy after you get infected, the better. And then you can intervene with different combinations, such as vaccines or broadly neutralizing antibodies, gene therapy, latency reversal agents, and then you interrupt treatment. And when this has been attempted, in some cases, the virus does not come back. The problem with this combination approaches is that sometimes they work, sometimes they don't work. And at the moment, we are not sure why they work in some people, but not in other people. So there's a lot of research that is going on to try and understand why it works in some people and why it doesn't work in some people. The other problem, of course, is that even in the cases where there has been remission, in other words, even in the cases where the virus does not rebound after antiretroviral therapy is interrupted, some people have rebounded after 6 months. Some people, it takes 1 year. Some people, it has even taken 2 years to experience rebound. So the time of rebound of the virus is also unpredictable. So in some cases, remission is not equivalent to cure, because the virus sometimes comes back, and it is difficult to predict when the virus will come back. And therefore, there is really you cannot really argue that that is a cure, because the virus will still eventually come back. But we need to understand what are the mechanisms that lead to cure of some people, or even to long-term remission, so that we can then try and improve on that, and so that we can achieve an HIV cure. The other approach is called gene therapy. I hope you're on that slide on gene therapy, Dom. In gene therapy, what you do is you target the latently infected cells, so that you can actually remove HIV DNA from those cells. or you can enhance anti-HIV immune responses, and also you can engineer uninfected cells so that they become resistant to HIV. And then, as I mentioned, you can also directly eliminate the virus itself from infected cells. So these are gene therapy approaches. These gene therapy approaches, however, tend to be very expensive. And at the moment, I'm not aware of any gene therapy approach being studied in sub-Saharan Africa because the cost is very, very prohibitive. But of course, in future, we hope that the costs of these gene therapies can go down. And so there is a lot of research going on in gene therapy research. So there are two forms of gene therapy. One is what we call ex vivo gene therapy. And in ex vivo gene therapy, what you do is that you take HIV infected, you manipulate that blood outside the body. In other words, you do the gene editing outside the body, and then you return and infuse the blood back into the person who is living with HIV. So that's what ex vivo gene therapy is. But there is also what we call in vivo gene therapy. And this is gene therapy of the future. And in gene therapy of the future, what we hope that it will achieve is that you will just need one single shot. And the gene therapy will then happen inside the body rather than outside the body. So that's why it's called in vivo gene therapy. And these are, as I mentioned, the main problem with gene therapy at the moment is that it is very expensive, but we hope that in future it will become less expensive and become available to people in resource-limited settings. So the other thing that I wanted to mention is that it is very important to involve communities in HIV cure research, because particularly in sub-Saharan Africa, we are the communities that are affected and impacted by HIV. And in order for us to move HIV cure research forward, we need to do the research, we need infrastructure development, and we need to engage communities so that communities can understand what is being done in the area of HIV cure research, because there cannot be any change. So I want to finish by telling you very briefly about a cohort that we have established in Durban, South Africa, where we identify women with acute HIV infection. So very, very early, as soon as they become HIV infected, we are able to identify them by screening high-risk HIV negative women twice a week by RNA testing. And that allows us to detect acute HIV infection as soon as somebody becomes HIV infected. And then we are able to give them antiretroviral therapy. And what we have found is that if you introduce antiretroviral therapy early, you blunt the peak viremia. So that the viremia in the people who are treated very early is much lower compared to the peak viremia in people who are not treated. And what we have also noticed is that when you treat people early, you also improve their CD4 counts. So the immune system is much better compared to people who are not treated during acute HIV infection. So we think that because the immune system is better, these early treated people have much better immune system, that they might actually benefit from an HIV cure strategy. So we are now in the process of doing a clinical trial here in Durban, South Africa, in these women who received treatment during acute HIV infection and have been fully suppressed for at least 1 year. And we are hoping to intervene with a combination intervention involving broadly neutralizing antibodies. Broadly neutralizing antibodies inhibit HIV replication, but also we also hope to intervene with an immunomodulatory agent known as toll-like receptor agonist. So these are the two therapies that we are giving, broadly neutralizing antibodies and toll-like receptor agonist. And then we are interrupting treatment, and we are following up these women to see whether the virus rebounds or not. The study is to see whether this intervention will cure HIV And if it doesn't cure HIV, we will also try and understand the mechanisms why it doesn't work. So that's what we are doing at the moment. So in conclusion, at the moment, we are in the era of combination antiretroviral therapy, where we are giving one single dose of one pill of antiretroviral therapy. Now, in future, we expect that long-acting antiretroviral therapy will be available. This can be given once every 6 months or so. And then we hope that other treatment modalities, such as broadly neutral antibodies, will be possible, and that this will lead to remission, and then ex vivo gene therapies and in vivo gene therapies will eventually lead to an HIV cure. We don't know when, obviously, this will be possible, but this is what scientists are working towards, is to try and develop cures that can be given as a single shot and lead to the cure of HIV. And that's the end of my talk. Thank you very much for listening. I am happy to take any questions.
Thank you, Tumbi. Thank you. That was brilliant and very clear and concise. So I hope our audience has been listening. Were we listening? Okay, so do we have some questions? Okay, first question, Tumbi.
Thank you so much. I really want to know, I was intrigued by the post-treatment controllers. You said these are people that have interrupted treatment in the early stage of their treatment. I really want to know if these people were tested after their interruption and they were seen, I really don't know, is that they were tested and HIV was not found in their bodies, or they were just left and yeah, I really want to know if it was undetectable or they were just left and they were not seen sick, or yeah, I just want to know that really what are post-treatment controllers.
Okay, did you get that, Tumbi?
No, I'm afraid you have to repeat it for me,
Okay.
Dom.
It was a question around post-treatment controllers, and specifically whether these were people who had gone off treatment and were just left, and we identified that they were ultimately controlling, or were these part of a structured program which we identified that they were controlling post-treatment?
Most of these most of these post-treatment controllers are people who stopped treatment for one reason or another. Maybe for example, some people have allergic reactions to some drugs, so they stopped treatment, and then they were sort of accidentally found to be controlling after they interrupted treatment. So that's usually what has happened. In most of the cases, when people interrupt treatment, the virus comes back. So in the majority of cases, in about more than 80% of cases, when you interrupt treatment, the virus comes back. So this is not something that is recommended that people should do. It is not recommended that people should interrupt treatment. But there has been a few cases, as I mentioned, of people who interrupted treatment. And interestingly enough, if they had started treatment very early during acute HIV infection, they actually control. So post-treatment controllers are people who start treatment early and who interrupted treatment, not in a specific program. Most of them were they happened to be to have interrupted treatment for various reasons, and then they were discovered to be still controlling despite interrupting treatment. And then there is a question here in the chat about, can HIV controllers infect someone? And the answer to that question is that in most cases, no, because they have undetectable viral load.
Thank you.
And you're not on antiretroviral therapy, but you're an HIV controller, you don't have detectable viral load. And if you don't have a detectable viral load, the chances of passing that virus to somebody else is almost zero.
The question for you. The key thing I just want to recommend is that no one should be interrupting their treatment to try this, right? It happens in very, very rare cases. It is being studied. Hopefully it will be better understood in time, and maybe it does become something, but yeah, no unsupervised interruptions, please. I saw a question here, and then we'll go to this side.
Okay, thank you, Mr. Speaker, for the beautiful presentation. I heard you talking about latent infection. Is it latent or infection cells? So I need clarity on the latent. Does it mean the cells are infected with the virus but not active? If that's so, how long does it take to be latent? I don't know if I'm clear. I need clarity on the latent. If does it mean if the cells are infected with the virus but not active? And then, yeah, it's clear.
Tumbi, did you get the question?
Please repeat it for me.
Yeah, no, it was about latent infection. I've also put the slide back up, and about does it mean that just that the virus is not active, but it's there?
Yes, that's correct. When the cell is latently infected with HIV, the virus is inside the cell, but that cell is not producing any virus. The virus is just resting inside the cell. So the DNA, inside the DNA of the cell, you can get the genomic information, genetic information of the virus, but you cannot actually detect the virus proteins. So the cell contains the genetic information of the virus, but it's not actually actively producing the virus. I'm not sure. I'm not sure whether that was your question.
I think you have. Yeah.
Okay.
So, next question.
Thank you so much. Thank you so much for the wonderful presentation. Oh, okay, sorry. Thank you so much for the wonderful presentation. But I want to take you back. I want to take you back to the post-treatment controllers. I didn't understand that. Does this means that if you interrupt treatment, you become HIV negative, or you become the HIV become undetected, or your body is just able to control it, say over 5 years, then the HIV will come back and show signs after that specific period of time. Thank you.
So to me, that was another question about post-treatment controllers and whether that meant that somebody was HIV negative. Did it just mean that it was under control? Could it mean that the virus, though, would come back in about 5 years' time? I think just more clarity about what you mean by post-treatment controllers, and I'll put the slide up as well.
So post-treatment controllers are a very rare group of people. Most of them are people who started treatment during acute HIV infection very early after they got infected. So usually it is somebody who started treatment within maybe about 3 months or so of getting HIV infected. And those people, when they interrupt treatment, again, I want to emphasize that it is not everybody who started treatment during acute HIV infection who becomes a post-treatment controller. It's only about less than 10% of people. HIV, those tests will be positive. So it doesn't mean that they have been cured of HIV, but for whatever reason, they are able to go into what we call remission. So it just means that they are controlling the virus, most likely temporarily. And again, what I said is that this period of remission varies. It changes from one person to another. For some people, they go into a remission for about a year and then the virus rebounds. For some other people, it might be 2 years. And this is what makes it so difficult even to study this phenomenon, because you don't know when the person is going to rebound. So you cannot just interrupt treatment because you don't know whether the person will rebound in 1 month or in 5 years. So it becomes very, very difficult. And that person needs to be monitored very closely because you don't want the virus to be replicating in that person, to start replicating, because if it starts replicating again, it will destroy your immune system, or you can pass that virus to somebody else. So post-treatment control is a phenomenon that has been noted, but it is not very clear why it happens. And it doesn't mean that somebody is cured of HIV. It just means that they're in some kind of remission.
Okay, so hopefully that was clear. Remission, you're not negative, and it happens in rare cases, so no one should be interrupting treatment in hope that this will happen. Okay, I saw some questions on this side.
Thank you so much for the presentation. From the previous speakers, we had that they were talking about this lady, is it Phyllis or something? She talked about treatment break, but we don't know that thing in Africa. So I want to ask, you said if you stop treatment within 2 weeks, then the viral load start to shoot high. So we know we are in Africa, most people default from treatment. So how risk it is for those people who have defaulted from treatment to be able to enroll into the cure of the HIV. And another thing, you talked about maybe 2 of the therapy for the cure, the gene therapy and the immune therapy. So my concern is that for it to be sure that it's efficiency, do you guys, maybe if you do the study, maybe take samples of the blood for those people to see which one is good for that person, for the person's system? Maybe take the samples to see, okay, this one we can work with the gene.
Okay, so if I got the question correctly, you are asking whether you are saying that some people in Africa default in terms of the antiretroviral therapy, and are these people, what is the impact of that? And the short answer is that if you interrupt treatment, you are less likely. The question was about okay. Yeah. Yeah, so first of all, just to say that the therapies that are being attempted for HIV cure Everything is experimental at the moment. So nobody can say for sure that it will work. So even those people who are doing this kind of work, including ourselves, it's an experiment that we are doing. It's research really to see whether this will work or not. And it could work, it may not work. If we knew for sure that it would work, we would give it to everybody. So I just want to emphasize that at the moment, it is all experimental work, and nobody is sure that this is gonna work. The other question is, can you actually test and see whether this drug will work versus the other drug? And the answer to that question is yes. At least in the lab, you can test and see this one is more likely to work. So for example, in the study that we're doing in South, which broadly neutralizing antibodies are likely to work, at least in the lab. We have tested the person's blood in the lab to see whether this thing works in the lab.
Another microphone right now, like this. Okay. Can you hear me, Tumbi, when I speak like this? No, I don't think he's hearing. Tumbi, can you hear when I speak like this? Tumbi, are you frozen? Can you hear me? Oh. No. Yeah. Can you hear me when you can hear me when I speak like this?
Yeah, I can hear you.
Okay, great. Are you good for 5 more minutes? Just a couple more questions?
So just to finish, what I was saying is that yes, you can test these drugs in the lab, but until you test them in the actual human being, in a clinical trial, you will never know whether they will actually work, because there are a lot of things.
Thank you. Thank you. Is it possible that when you get the cord blood cell transplant, and then after some time you get the rebound? And then another question is it possible that there are any allergies or effect that it can make to someone living with chronic diseases?
Did you hear that question?
No, I did not.
Could you come up? Sorry.
My question is it possible that when you get the cord blood cell transplant, you have a rebound after some time? And another question is it possible that the cord blood cell cause allergies or negative effect onto someone living with chronic diseases?
So, sorry, you get what? Can you ask the first question again?
Okay, my first question is Is it possible that
when you get the cord blood cell transplant, and then after some time you get the rebound? And then the other question was, is it possible that the cord blood cells transplant pose a negative effect onto someone living with other chronic diseases, like maybe cancer, something?
So again, even the cord blood transplant and even the bone marrow transplant, all these are experimental procedures. So they have worked in a few people. Whether they can actually work for the general population is still very debatable. So I wouldn't, just because someone has received a transplant doesn't mean that they can be cured of HIV. Yes, it's true there are a few people who have had transplant and they got cured, but whether that's going to become a general principle that everybody who receives a transplant gets cured, I don't think that's clear yet. So we need more of these experiments. We need more of these clinical trials to really tell us whether this kind of approaches will work. And then the other question was whether I think the question was whether the person can transmit, the person who has received the transplant can get other diseases from the donor. And the simple answer is yes. So remember, this is done in highly specialized medical facilities. So they really will test for all kinds of infections to make sure that you are not getting a donation from somebody who might have a condition that can be transmitted to you if you're the one receiving the donation.
Great. We've got another question, Tumbi. If you're okay, we'll make it this one of the last ones.
Greetings. My question is, at the beginning of your presentation, you showed us how the treatment has evolved over the years, and now we can have injections and whatnot. So what I'm asking is, how are you guys working towards having the injections free, so that we can get the treatment via the injections, since there are a lot of things that we go through, the pill fatigue. At this point in Swaziland, you can get the injection, however it's very expensive, so we don't have that money, more especially us young people. It's hard for us to afford to get that. So how are we working towards taking it a step further and seeing technology evolve, the treatment evolve as well? How can we work around that?
Yeah, I think if I got it correctly, it's about the cost of the long, particularly the long-term antiretroviral, and this is a real problem, because even though these drugs have been approved by the regulatory agencies, they actually are very expensive. They tend to be too expensive, so most people are not able to afford them. And I know that there is a lot of advocacy going on both at the WHO, World Health Organization level, but also with the drug companies that make these drugs, to try and bring prices down. Because at the moment, outside the reach of most people who are living with HIV, the hope is that the costs of these drugs will come down in future. But I completely agree with you that at the moment, the costs
for taking what is complex science, and I think generally understandable. You understand the big ideas, yeah? We're on a journey, long acting. How many different strategies are there to cure? Huh? 2, yeah. What's one? What's one strategy? Eradication, what's the other one? Yeah. Okay, can you name 2 types of gene therapy? What was one? Outside the body? Ex vivo, in vivo. Tumbi, I think they were listening. They were able to answer my pop quiz. So thank you for your time. Please give Dr. Lungu a huge round of applause.
Thank you. Thank you so much.
As always, really appreciate the support. So thank you.
And
so
hopefully,
much.
hopefully next time it will be in person and
Yes.
it will be a little easier to communicate. But thank you very much for the opportunity.
There's lots of smiles in the room to the idea of in person. So we will aim to do that next time. So with that, thank you, and we'll let you go. We have a few minutes before our scheduled lunch break. So before, I've got a couple things I want to say, but before we do that, are there any questions or comments you want to make about the presentations today, the questions, just generally? It could be from Supercharger, from Philister, from Tumbi. Any thoughts? No? Yep.
I just want to appreciate to be part of this platform. I think it has given us the hope that sometime the sun will rise. Like we work with more young people, so if we come across many challenges, even us, we are faced with a lot of challenges adhering to our art. So having this kind of conversations sort of give us hope that one day we will make it. Although some of us started this treatment a long time ago, we come with drug fatigue, we come with no love relationships, to disclose to the one that you love. Hey, this thing is so challenging, but I am very happy to attend such gatherings. I am sure that in the near future we will have people championing and celebrating that finally we have come with the cure of HIV. Otherwise, thank you very much, Mr. Dominic.
Thank you, and I'm glad that that resonates and you could see potentially what the journey looks like and the impact. I would also say is that we've been talking about cure today. We've mentioned long-acting, 2 months, but there are trials right now going on for drugs that are looking at 6 months between treatments, So there are steps that we're going through, that before we get to a cure. But I hope that there is hope for everybody. Any other questions?
Thank you. Thank you so much for the presentations. I would just like to highlight mostly on the issue of stigma and discrimination, because I feel like it is one issue that we'd have to tackle more before we even get an HIV cure. Because I feel like in the world or in the country that we live in, even after the cure, I feel like we'd still have stigma. People will have it hard to believe that there is HIV cure. So I feel like we should tackle that more even before we get the HIV cure.
This is one of the most critical points, right? If HIV was just about a medical condition, it would be over, right? Because we know that treatment is prevention, and if everybody was on treatment and everybody was taking their treatment, there would be no onward transmission, and we would bring people in early, and but we know that HIV is perpetuated because of social issues, because of stigma, because of attitudes towards key populations. I think you're absolutely right, because you could end up in a situation where we haven't dealt with the issues that divide us, that breed kind of division, hate, or whatever, lack of acceptance, but we have a medical answer, cure, that kind of brushes that under the table. And we still then look at people who do sex work or MSM or trans in another way, right? And I think that we need to figure out a way to continue to double down on stigma and discrimination, and maybe cure is one way that we do that, because we could talk about that message of hope, but part of what one of the things that I said about today is the beginning of the beginning, right? So hopefully one of the things that comes out of it is what you think might be a plan for what Eswatini can do in the future. What are the steps needed? And maybe stigma discrimination is right at the heart of that plan.
Thank you, Tom. I think from what Hlanga is saying, it's honestly very critical, especially because as we speak with about the cure, then like we're discussing that we need to find a way to say after these workshops what's going to happen, because it's not just a touch and go. Then there should be some follow-ups, dialogues, or what are we supposed to do as advocates. I'm just going to put all of us here on the spotlight to say we are advocates. I know it's not easy to be in the journey living with HIV so many years, whereas when we become a key population, either in MSM, we are gay, we are lesbian, or transgender cure. So, but then the one thing about stigma that I've seen, it is the self-stigma. Right now, it is so very high because I'm just going to exclude myself and not partake on certain activities until people are like, oh, what's wrong with Precious? You know, people, they start digging, but I've already given them some highlights to say something is wrong, something is wrong, something is wrong, until then they get to know, oh, she's living with HIV. And now I'm saying people are being stigmatizing me when I've already excluded myself and said I can't do this because I'm like this, you know. So I think one critical thing, especially when it comes to young people, one critical thing we need to work around, it is self-stigma. It is different with us as adults because I know a lot of things have happened. There's rejection, especially young people when it comes to stigma. It affects the dating life. You know, you want to be loved, you want to love. You know, you need to live like beyond being HIV. So I think one critical thing is that we are in the closet. Trust me, disclosure is a personal decision. But, and also coming out, it liberates you. So the more you are in the closet, the more you don't want to partake to activities or program that relates to who you are in the literal sense becomes very difficult. And I will just make an example. Let's look at the key populations. Previously would have those, when somebody says, oh, I'm lesbian, like, but now it's normal when somebody says something, like, okay, because, you know, the more people who are seeing to say, oh, it becomes normal. But the more we try to hide and hide and hide, then it becomes very difficult to deal with stigma because there are known people. I'll make an example. We work with a lot of partners, and they're like, Precious, where are the young people living with HIV? Because every time we need to talk about HIV, we are seeing you. I'm like, oh, the young people are not comfortable. I'm protecting the young people. I want to make sure that they speak when they are ready. And the one question they're like, we are not asking all the young people to be ready, but are there those few that already speak? But one thing I've learned is that they speak in the long run. It affects the relationships. It affects the dating. One day you will be Googled, and then like the guy will be like, oh, I saw you're HIV positive. Like when you would have to press my name on Google. You said, Precious Strong, HIV positive, woman living with it. Already your life is out there. So, but then one thing I've seen most countries, I'd make an example. I've made a lot of field visits in Uganda, and one thing that is making easier for them to even have such initiatives where they can talk about cure freely, be in the trials, is because taking medication in Uganda is just a community thing. The community support each other. When it's time for refill, your neighbor will be telling you, oh, Precious, the car is here, or they quickly rush and pick the treatment for you. But here, that cannot happen. It is always undercover. Yes, we will get to a point where we get there, but then things are not just going to happen automatically. At some point, there will be some of us that would have to come out and speak about the issues and face the rejection and face the tension and face those sleepless nights, teary eyes where you are undergoing through a lot, but then you are paving way for other people. That is what I can say.
And I think this comes back down to the comment earlier about mental health, right? And mental health, sometimes we talk about it in the context of like a problem. But just being confident is a mental health issue, right? It's about, in terms of being mental health positive. So I think those are the things: self-esteem, mental health, accepting who you are, you know, and then when you're ready, being open with that. That is a big part of the conversation. So it's just about lunchtime. So what I'm going to do very quickly is, normally at the start, if we didn't have some of the tech issues, I would do like a 10-minute kind of talk and then a discussion. So I'm going to do the first bit of that talk right now, take me 4 or 5 minutes. We'll go to lunch, and then we come back, I'll do the second bit of my discussion because that opens a conversation, right? And we'll have that conversation about perspectives around cure now, and then we're going to spend the rest of the afternoon, just an hour and a half or so, in breakout groups. And what I want to do, this session has been a little bit about opening a door and introducing the topic of cure, but what we're really keen to understand are a few things, like what is your current understanding of cure? Now, we normally do that before Tumbi's presentation, but because of the tech issues, we'll do it afterwards. That's fine. So what is when you walked in this morning, what was your understanding of cure? What is it now? And then the second thing is, I want us to start thinking about, if we are going to do work around cure moving forward, what do we see as some of the challenges to do so? Individually, so the issues that Precious and others have referred to, but also as communities, okay? And that's what we're going to do this afternoon. But before I let you go for lunch, let me just quickly say why I'm here. I think it's always good to tell people why you're there and why hopefully you're deserving of their time. So I work with an organization called the HIV Cure Africa Acceleration Partnership, and this is based at Georgetown University. Now, you might say, why does an Africa-focused cure initiative based at an organization in the US? And that is due to some very complicated politics going back 3 or 4 years ago. But there was a guy called Mark Dybel who used to be the head of the Global Fund. Before that, he was the first PEPFAR ambassador, or one of the first PEPFAR ambassadors. And he was at Georgetown, and Cure was, he saw that as there was a global convening, and there was he wanted a real focus on community. And when that global convening said, actually, yes, we are going to prioritize this, he said, well, we'll set up HCAAP and we'll run with it. Now, we've had a second global convening last year around this. Actually, it was the third, but the second in terms of the history of HCAAP. And what we agreed is that HCAAP will move to become an African organization, an African entity within the next kind of work plan cycle. So we're going to move to transition the organization, and there are lots of discussions about what that might look like moving forward. But for right now, HCAAP is based at Georgetown. And our goal, our mission in life, there are 3 things that we're doing. So one is, you will get to know if you get involved more in the cure space. It's a very collaborative environment. It's not like other areas of like drug development where a company maybe goes off and does something. Right now, you've got researchers, companies, academics, communities who are working together. Now, as I said, a lot of this is happening in North America, but we are knocking on the door saying we want more people based in Africa to be part of this, and that door is wide open. The openness, the willingness to do that is there. And so a lot of the organizations that I think Supercharger mentioned, like Caring Cross, ourselves, AVAC, others, you know, there are opportunities. They're limited, but there are opportunities at this stage, but we hope to grow those opportunities with time. So the first thing is HCAAP is trying to improve collaboration where it's needed. So to create a platform, and when we say where it's needed, our focus is on people here, ensuring that they are part of the collaborations that are taking place. The second thing is, it's just a project which we're nearing the completion of, and it's called a target product profile. So HCAAP is leading the development of a target product profile for an HIV cure gene therapy. And what a target product profile is it's trying to set a clear goal as to what we think an ideal or a minimal product would look like, a cure product, a gene therapy product. Now, it doesn't mean that the actual product will look exactly like what is being described by the TPP, but it gives an indication of where the direction of travel is, what we should be shooting for. Individual organizations, collaborations will make their own decisions about what they pursue. Regulators and others will obviously be very clear about what they will approve, and individuals will be making the decision about whether it's something that they want to accept. Absolutely fine. But at this early stage, it's about setting a direction that everybody can buy into about what is needed. And the third area, and this is where we're spending most of our time, is around what what a lot of people refer to as community engagement. I don't really like that, because we're not trying to engage. We're trying to activate and get people excited about the potential for HIV cure. A lot of this science, like the gene therapy stuff 10 years ago, like there was very little happening. And then in the last decade, there's been massive advances in gene therapy. Gene therapy's been around for some time, but there's been something called CRISPR in the last decade, which has revolutionized the way we've seen things. And so there's real hope. And in one associated condition, sickle cell disease, which affects children in Africa more than anywhere else in the world, there's actual gene therapy treatments that are now being rolled out, and trials, things like that. They're very expensive, but the idea is can we get more products? Can we drive down the costs of those products? And can we make sure that they're available to the people who are most affected, or the countries most burdened by sickle cell disease, i.e. countries in this continent. And the reason why sickle cell is important for HIV is that one of the gene therapy strategies, which I won't go into the detail of, may be appropriate for HIV. So you assume the same process, but for targeting a different disease. So a lot of our community engagement work, this activation work, is just initiating this workshop, developing a partnership like the network here, and then hearing back from you in terms of what you want to do moving forward. And our goal, what we're trying to do, is we're trying to raise funds to help support low-level activities. We don't have, I'm afraid, tens or hundreds of thousands, should I say, of dollars right now to help support loads of cure activities, although I don't even think that is what is needed right now. But what we do want to do is say this is a starting point, and we will try and support communities on that journey in terms of things they might want to follow up. The two other things in communities that we're doing is, because one of the things that have come out of discussions in other countries, and I'm sure will come out of the discussion here, has been the lack of availability of materials. Things that you could use at the community level, things that you could use to learn for yourself. And so we're working on those with partners, and we'll invite the network here to help input into the development of those materials. The idea is to develop something that is useful, obviously, and does help build learning, but is also generic enough that you can adapt it in terms of local language, communicating in the way you want to. We're also working with some other partners to update. There's something called a cure curriculum that's available online, and we're trying to update that so that it's a little bit more Africa-centric, reflects more these conversations. This is a slightly more longer term. I imagine it will be middle of the year before the next version of that will be available. But that will be something that, I mean, you can access the current version now, but in the future we hope, for those of you who come out of this workshop today and say, actually, I do want to learn more, I do want to be more engaged, that will be there for you. We'll also, where possible, we'll connect you with like conferences and webinars, as we talked about earlier today. The idea here is just to hopefully sustain your interest, help support you in your development and some of the activities you want to do. But those activities after today need to be defined by yourselves. I can't come from outside Eswatini and say, this is what you need to do. This will be up to what you want to do. So that's a little bit about HCAAP. I will talk to you a little bit about the other stuff after lunch, but I would like to thank you for your participation, all the questions, really good discussion, really good questions. Lots of interest in post-treatment controllers, I see, which is interesting. We will resume in an hour or so. So thank you, and enjoy your lunch.